we actually have plenty of time. We have 25 minutes to get some discussion. And by the way, there's a microphone on the back. It's a little hidden, so to get there, it will be hard. But there's another one over there. So if there's any questions from the audience, we'd love to entertain them.
There's one microphone.
There's one microphone on the other door as well. In the meantime, will people have any questions? Maybe I can ask, just start with asking actually everyone, how many people use ultrasound for getting access? Oh, that's great. So it's more using. How many people use micropuncture? Wow, you guys don't need to be here.
We're going to be invited next year.
No, I think there's obviously radial. I believe you're right. Has less bleeding complications, but if you do femoral well, I think you can decrease the risk significantly. So, and there's been always some cases, and I'm a firm believer for the very complex cases going big and femoral because you may actually have what I call the lethal risk, very bad things happening, and with a 6 French radial, you might have a hard time doing this. Great. So any other questions? Maybe go back to Anna and then ask a question. You had issues with thrombus. So I just had a case of a large thrombus in an acute STEMI. The patient was fine. I tried to mess with it. The patient arrested. And going after this, it was a huge thrombus, embolized, couldn't retrieve it. Is there other times where you may tell people maybe it's just best to leave it alone, marinate it with the coagulation and 2B3A and then come back? Or what would your thoughts about that?
So I think it depends on the flow in the vessels. So if you don't leave the lab in a STEMI situation with TIMI3 flow, your prognosis is not good. So I think trying to do what you can in the lab to reduce thrombus burden, restore flow before they go up to the unit is the right thing. Obviously, that's different than in the periphery where we marinate thrombus and give lytic catheters and so forth. But my principle is I try to get the best possible flow up front in the lab rather than marinate and wait, which is not always possible.
Yeah.
Do you think that just bolus dosing of 2B3 rather than the drip, just do bolus dosing, use a newer P2Y12 inhibitor, IV Candelor, and
Okay, so yeah, actually, Dr. Mahmood, who I trained under, he and I, several years ago, we published an article on that where, certainly for the acute event, the bolus is quite helpful, and now coupling that with the use of potent oral antiplatelet therapy, ticagrelor or prasugrel, is a good strategy. With cangrelor, it's expensive. It would have to be run for a while, and with cangrelor, you really need to use ticagrelor if you're going to switch to an oral agent. It's a little more cumbersome to switch to clopidogrel afterwards, but yeah, I think that's a reasonable strategy.
Yeah, I'll just go back. I think, especially for STEMI, but really always, adequate P2Y12 inhibition is essential. And I can tell you, I've just shifted from Minnesota, where we had a very standardized protocol and pre-treatment, to Los Angeles, where lots of people get into the lab quickly. And this, with STEMI, this slow flow that you see, I'd forgotten that existed, right? Because when you have good pre-treatment, you very rarely see it. But now if someone gets to the lab in 16 minutes, right, then you don't have adequate. So I think two things. I think for selected use, cangrelor is really effective. And I personally have, I try to avoid 2B3 inhibitors just because I think of the bleeding complications. Not that they don't work. And especially the patient population that it's most essential, out-of-hospital cardiac arrest, cardiogenic shock, because you might not have you either can't give the oral P2Y12 inhibition or it's not absorbed. Well, that population are the highest risk of bleeding. So that in particular, I think there's a selected use for cangrelor. And it's actually, if you look at the cost, and I will say with tirofiban, I'm not sure where tirofiban goes. That's a different thing. And the way it's being used bolus, there's a few labs that are using it, and there's almost no data to compare it. But if you're talking about cangrelor selectively, very selectively, it's cheap, just as inexpensive or similar to either ReaPro or Integral. So, but selectively. the biggest thing I think is having good P2Y12 inhibition on board. And that means like for either ticagrelor or prasugrel chewing it. If I'm not sure if somebody got clopidogrel and they're not sure, I frequently give 60 of prasugrel and have them chew it. But I think that really helps prevention.
Sure. Great point. One more question from Mike Luna. So the cover stents are great, but we have only the graft master, right? And sometimes it's very hard to get it down, especially in those complex calcified vessels. Any tips and tricks how to get them down?
Yeah, so doing complex PCI and CTO PCI obviously helps your skill set, but getting a guideliner down using buddy wire technique, all those things are very useful in those scenarios. I think for graft master delivery, especially in very calcified, using the technique of coaxializing the guideliner and getting it as distal as possible past the site of injury. Gives you a much smoother delivery of the device, and so now I've never actually delivered a graft master through a 6 French guideliner, and I don't think it'll go. Yeah, and so that's a consideration. If you're having that issue, you may have to consider switching out, doing ping pong technique, keeping that guide, second access, ping pong. We'll try a wire, and then using a bigger guide. But speaking of the guideliner, just medical therapy for sure, I think is critical in these types of large thrombus burden patients. But remember to always consider real-lytic thrombectomy, obviously, and guideliner-assisted thrombectomy is an important one that's missed. Manos and I did that obviously a lot in training, and it does work. And it doesn't always work, but it does work in selected cases where you have a lot of thrombus burden. Essentially, you get the guideliner down into the vessel and use your guide catheter with the guideliner and your TUI or co-pilot as your aspiration mechanism. And so you have to make sure to size the guideliner to your guide catheter. So you can't put a 6 French guideliner in a 7 French guide or 8 French guide. You have too much space between the guide catheter and the guideliner. You need to match that nicely. So 8 French guideliner, 8 French guide catheter, and aspirate from the side port of your TUI. Works very well in a couple of cases we've had in the past.
The other technique to think about, and don't do this all the time, obviously, but to open up a spider filter or an easy filter and actually use that to snare the thrombus and then close it and bring it back. Obviously, you can dissect the vessel, you can do a lot of things, but that's a technique I've certainly used before.
And I think it's worth making another comment about perforation as well. I've now had a chance to work in multiple different large labs with lots of different people, and the percentage of perforation varies a lot. And one of the key things is we are past the age where we should be overinflating. And I think when you should look in your lab and look where the perforations are. It's one thing if you're doing aggressive CTO things and you're going to have some then. But just in standard PCI, the number of times that you should perf should be extremely rare. And if you look in your lab and say, why did we have this many perfs this year, that's something that you should look at preventing. Because, taking an 85-year-old lady in a proximal LED and putting up a 5.0 balloon, really? Are you sure you should have done that? And I think if you look at perfs, overinflating there's no need, right? With the new generation stents, there's no need. And so I think from a lab standpoint, how many do we have this year? Should we really have had them? Is there a reason, or could they have been avoided?
Coming back to the issue of the cover stent, so actually we had the privilege of having one last week and couldn't deliver the cover stent. Despite having externalized wire, still couldn't deliver the cover stent. But so 6 French guideliner doesn't work, 8 French works. But even with that, if you preload the graft master and the guideliner and then put it as a together versus just alone, actually it's better because you can get it further down as long as you get the guideline down there. But that worked. And actually what happened is the graft master got deformed and we had to recrimp it. So then if you do that, you obviously don't want to put it back. You have to put it through a guideliner to go down there. But that's a great point. One question, anyone uses laser for thrombus? Like when you have a lot of thrombus, you cannot get really much flow there. Anyone would use laser for that to kind of ablate through and get through?
Yeah, I have with not great success in the past.
I had an interesting case a couple of months ago with saphenous vein thrombosis. Tried to aspiration, a lot of intracoronary vasodilators, nothing worked. Did laser therapy and actually got some flow back. It wasn't the best result, but we got something down the corner and down the vein graft. So.
Sure, having more tools is good. And another point is about balloon rupture. I think Mike mentioned sometimes balloon rupture can injure the vessel and cause perforations, dissection, things like that. And actually, the case I've been burned where I did that and I didn't realize it until like 2 minutes later. So since then, every time I have a balloon rupture, I take it out and take a picture immediately just to make sure. I don't know if people have any thoughts on this and when that happens and what to prevent.
Yeah, that's happened to me because I was trained by you, and so there you go.
I was trained by him too, and that hasn't happened to me.
So when that has happened to me, I'm in the habit of immediately calling for a balloon. I need a replacement balloon. Just have it on the table, get it ready, and then do an angiogram right away. And so it cuts down on the time for sure.
Human, quick question for you. You talked about the differential between having dissection, having intramural hematoma, having spasm. So is IVUS the answer? How do you, because you're stressed out, right? This happens, you're stressed out. How do you sort this out? What are the practical things you can do to sort it out? Is IVUS the answer? Nitro? What is the thing? What is your sequence? I know you mentioned something, but like for the people, what's the practical way to do this?
I mean, yeah, starting off with nitroglycerin and sort of vasodilator, I think if you have a spasm, underlying spasm, that would help. You get some flow down the vessel, you could probably kind of rule out spasm as a potential contributing factor. Getting intravascular ultrasound is a great tool to differentiate between the dissection and intramural hematoma. You can think about doing optical coherence tomography with OCT. The downside of that, of course, is if you have a dissection, you have to do a heart injection with contrast of D5, and you can propagate a dissection flap further down. So I would probably avoid OCT imaging for if you have a dissection and you don't know if you do have one or not. But IVUS, I think, is extremely useful in these cases to rule out a dissection versus or intramural hematoma. Again, I think it's also a microcatheter. I mentioned briefly using a microcatheter to differentiate between a no reflow situation versus a dissection or a thrombus in the lesion can be extremely helpful. If you have no idea what's going on and the IVUS may not be helpful, you might have missed it. Using a catheter to figure out what exactly is going on, inject the distal to see if it's, in fact, no reflow situation from distal embolization versus a dissection can also be extremely helpful.
And a lot of times you don't have good flow to get good OCT images.
Right,
exactly. Contrast, really. What about, I've had some, like this last LED you showed where the embolus was all the way down at the apex. Many times when this happens, I just kind of mess up the tip of the wire and just push it as far distally down to a side branch rather than keep it in the main vessel, if that's something that can help. Just so you have a smaller MI, I think, at the end.
Daughter it a little bit, yeah.
Just daughter it, take it down as far as it goes. I've had that even in the peripherals where something happens in the trifurcation vessels. Instead of having all three, you save two and then you let one go down to the knee or something. If there's no other way to take it through.
I'm kind of curious, back with the perforation, Luna mentioned for perforations and he does in reverse anticoagulation. How many on the panel would reverse it? How many wouldn't? Or would?
So I can tell you at the beginning when I first started, I reversed. I've had some, I'm actually showing one tomorrow. I had to reverse the calculation because you're anxious, But now I actually argue you don't unless you absolutely have to because of issues with thrombus in the arteries, which becomes a much more difficult thing to deal with. So I think as a young operator, when you see something free flowing blood, you get anxious. But as you get more experienced, I think if you can control things without reversing, I think that's the way.
Would you stop the bivalve route if you're using
So
a it gives you a little bit of time to still work.
I would stop the bivalve route just mainly because its effect is going to be there for the time when you're working, unless you're going to work for another hour or two. But yeah, I would stop the drip if you have 10-15 minutes, and then if you control the big curve and you want to continue your procedure, just restart the drip.
I think right in and out's better than trying to get protamine or breastfeeding.
Yeah. Obviously, it depends on the extent of the bleed and whether you can put a covered stent in or not. But I think I'm loath to reverse it. I think what you want to do is stop it, whichever one you're using. But reversing it can really, because I completely agree, you can make it worse if you somehow get a very thrombotic coronary, and now you have ischemic complications on top.
Yeah, I've seen a case where it was reversed and a cover stent had to be implanted, and about 30 minutes later, a cover stent just clotted off.
I have from a colleague of mine the same case.
So Mazen, every time I learn from you something about happening, so it turns out the radial has complications too. That's good to know. But actually, I'm curious for you. You saw the case where you had this perclose complication. I had a case recently where I got access and looked awful. I mean, probably dissection, something in the common femoral. So I called the vascular people. I said, I'm just balloon that. And they almost killed me. They said, what are you talking about? Just go and do something. Or actually what they said is just finish it, pull it out, and then hold pressure and see how it goes. It actually worked. But I'm curious, I mean, in that case, obviously you have to do something. If you go in, you have some common femoral kind of dissection or the flow is not the best. I mean, what do you just leave it or percutaneous or surgery? What are your thoughts about that?
That's great questions because we do see most of these dissections I showed you, most of them were left alone. The only, if there is a dissection looks bad, first thing I do is go contralateral or radial, whatever you want to do. You can go radial, left radial because you can reach very easily. And try to get a wire in the true lumen. That can be tricky. But if the dissection is from below, usually you can go in the true lumen from above because that's why we go either up and over or from the radial. And then what I do is get a small, like a catheter and just measure pressure gradient. I'll put an 014 wire so that I don't lose wire access. With a 2E, I'll measure pressure with a glide catheter or something small caliber. And if there is a pressure gradient in the iliac system, you usually need to stent it, unfortunately. Or you can tuck it with a balloon. If the balloon works and you can tuck the dissection enough, that's fine. If there's no significant pressure gradient, just leave it alone. Even if it looks very ugly, just leave it alone. Just follow with ultrasound.
So most common femoral dissections from the wire, because the retrograde flow is the opposite, you can usually manage that conservatively.
Absolutely. Absolutely. Even if you put a sheath, and it's not only a wire dissection, you only see it after the sheath is in, so now it's a little bit bigger than a wire. But most of the time you can manage conservatively. Totally agree.
Great points. Again, if any questions, please let us know. Just before just finishing up, just asking people if they what do they have in your lab for complications? Like, for example, in our lab we have a CTO card that has the coils and the cover stents in there. Just curious when we could go down the panel and just see what everyone has in their lab and how do you take care of these people? Do you have a specific infrastructure? You just call people? How do you typically do this?
Well, I mean, you were in the lab before, so you organize it pretty well. But yeah, we have coils, we have cover stents, all essentially in the CTO card. We have it all available and handy in case something goes down. So cover stents, coils available, ProGrade, these monitoring catheters for delivery of coils are also available quickly for use.
We have two carts, a CTO cart and then we have a TAVR cart. The TAVR cart has a lot of goodies, so Graph Masters, Coda Balloon, all those things. So.
For me, it's a little different. County hospital supplies and the UT hospital. And so UT, I have everything in a CTO cart. At Parkland, we share things with IR, and so we know where everything is. We can get quickly.
Yeah, I'm going to change it a little bit. We have in Cedars, we have multiple different labs, so it's a little more complicated. But one thing I will say also that's been really enlightening to me at Cedars is twice a month on Tuesday morning, every complication that we have, we review, and the interventional cardiologists present them. And it's really, really enlightening, I think. And it's not just like a cath conference, not like an M&M. It's every complication, any major bleeding, any perf, any MI, any stroke, any death are reviewed. And it's very insightful, and actually it's terrific for your interventional fellows too, because they get to see a lot of them and have that discussion about what could we have done differently.
Yeah, so we have the things, but we have the luxury of having the two hospitals, the VA and the University Hospital, just across the street from each other, and because the cover stents are not used a lot, thankfully, and expensive, can expire, I took the decision of having all the sizes available, half at the VA, half at OU, and we literally can go in 5 minutes if we need a different size. And this was less cost for each cath lab. But it works in ours because geographically it works for us.
Can you clarify for everybody the IRB implications?
Yeah, so every time, so this is a humanitarian device use only. Whenever you use the covered stent, you have to have a protocol for the IRB that's renewed every year with a PI, as if like it's a study, even though it's really not a study. And every time you use the covered stent, you have to write like a summary of the case, why you used it. It has to be a coronary. I can tell you one time, long time ago, when I was a fellow, one of the attending used one of these covered stent on a perforated tibial vessel, and almost the FDA came to our hospital because these are for coronary use only, humanitarian use. So if you have a perf and a peripheral vessel or something think a lot before you use one of these coronary covered stents in the periphery. I can tell you from experience. But there's a special form you have to send to the company as well as to the IRB, and that's how you also get replacements for your stents, and they keep track of the usage in your hospital.
Perfect. And then last point, since Dr. Mahmood left, that's about radiation. So radiation, something people are worried, but now I'm hearing more and more lately that many people are saying, you know what, radiation doesn't matter, we've been doing this all over long, and it's overrated, radiation's not a big deal, and we shouldn't worry about it. I have my own opinions about this, but I'm just curious maybe on the audience, do you believe that radiation is a bad thing for the operator and the patient? So I have this, there's, and if it is, maybe you can go down the panel, like, what is the one thing you think is the most important? Is it the 6 frames, or is it not stepping on the fluoro, as Dr. Mahmood said? I mean, what is your number one, tip and trick for minimizing radiation, apart from having an obsessive person screaming at you like myself? But.
Other than hiding behind the fellow.
Yeah. Yeah, I think screaming at the fellows, it works, it's very effective, it really instills it, just like you did to me.
So I think it's worse, and Shami did a really nice job of doing this, but now there's a lot of our audience here. There's 2 things I think that in CCI in the last year that I ended up writing. Number one, there's a survey of SCI members that showed occupational injuries, and it was almost 49%. So ortho, radiations, etc. And the second was, I just did one with my son who's an ophthalmologist, and it was a review of cataracts and increased incidence of cataracts in interventional cardiologists. 2 things that strike me about that. Number one, shockingly little data, and even almost no data on cath lab staff, whereas we know this is an issue. So this is something really as a field where we should be more aware of, that we should actually be monitoring. There should be lots of data. And then we should be doing things to impact it. But I think that the concern for left-sided tumors, and now I personally think the younger generation is better. How many people in here wear leaded glasses?
They don't work, by the way.
How many people have leaded in their hats? Yeah, good. That's impressive, because that would have not been in my age, and I do neither still, which is ridiculous, right? It's really an important thing.
Right, well, again, thank you all so much. I think it's time for the break. We'll continue. We'll have at 10:30 more complications in a session with the worst complications with Dr. Speedy and Dr. Grodin. So thank you all so much.